Well, hi everyone. Jake here with IBPF, and I want to thank you all so much for joining us on today's webinar on the topic of best practices for establishing and maintaining boundaries in interpersonal relationships. And today we're honored to be joined by Dr. Stephanie Freitag. She is a licensed clinical psychologist based in Brooklyn, New York, and she runs her own private practice where she treats patients in 5 states. So I'm very excited for this talk today. And Dr. Freitag, the floor is all yours.
Awesome. Thank you so much, Jake. Thank you everyone for having me today. I'm really excited to be here. It's my second talk with International Bipolar Foundation, and I love the mission of IBPF and all of the incredible tools it offers folks with lived experience and their families in regards to psychoeducation and other resources on bipolar disorder. I decided upon the theme of this talk for a few reasons. As a practitioner of interpersonal and social rhythm therapy, just one of the gold standards of care for bipolar disorder, one of the main premises is the ways in which social stress can impact mood symptoms. While the therapy provides some guidance on navigating interpersonal relationships, there are certain gaps that I thought would be useful to cover in this talk. As a therapist who is relationally oriented and a practitioner of other treatment modalities that emphasize relationship-based skills, I thought, why not bring some of that knowledge into this discussion today? So today I'll be talking about research concepts and evidence-based skills that I hope you will find helpful in your everyday life. I'll also be inviting some questions at various points during the presentation if folks want to chime in at any point. So this is the basic structure of the talk today. I also want to leave plenty of time for discussion at the end so folks can ask any questions that you might have. I also have 1 or 2 slides, like I said, where I'll invite some discussion as well. So quick note, I give credit wherever I draw from treatment protocols and paradigms. One of the paradigms I draw from is STAIR, which stands for Skills Training and Effective and Interpersonal Regulation, which was designed within the VA system for individuals with complex trauma. And it has many useful skills that I incorporate into my work, particularly pertaining to navigating and maintaining interpersonal relationships. I also include skills from Dialectical Behavior Therapy, a treatment that was initially designed for individuals with BPD, though it has been subsequently used with many other populations, and it's actually now even taught in schools for the general population. I'll share a little bit about my background. Some of this is redundant based on what Jake just shared, but I'm a licensed clinical psychologist specializing in serious mental illness and severe psychopathology. I also work with families who have relatives struggling with serious mental illness, as I have lived experience with a relative in this area. And just so how I define serious mental illness, it can be defined differently across contexts, but generally it includes psychotic spectrum disorders, bipolar disorder, and major depression with psychotic symptoms or treatment-resistant depression. Severe psychopathology usually encompasses more complex presentations with multiple co-occurring disorders, such as substance use, and personality disorders, such as borderline personality disorder. In terms of my location, I'm based in Brooklyn, but I treat patients in New York, New Jersey, Georgia, Florida, and Connecticut. I'm adjunct assistant faculty at the Emory School of Medicine in Atlanta. I did my version of a residency there, and my appointment includes involving publishing on bipolar disorder. While training there, I helped operate the bipolar clinic at Grady Hospital's outpatient clinic, and I ran a group for interpersonal and social rhythm therapy. Outside of my clinical work, I'm passionate about advocacy related to confronting the stigma associated with serious mental illness. And I care deeply about the advocacy component because of having a loved one with serious mental illness and how it's impacted my family. I think, unfortunately, our system often fails people and their families due to major gaps in care and a lack of prioritization of mental health within the healthcare system broadly, especially for underserved groups. That's part of why I really enjoy giving these talks, so I can provide relevant education and research. So before getting into the focus of this lecture, I always like to share a bit on the nuts and bolts of bipolar disorder, in part to normalize how many folks are living with bipolar disorder. I also like to demystify the diagnosis and confront so much misinformation that's out there. So in terms of the basics, about close to 3% of adults have bipolar disorder. There's a similar prevalence for males and females, around 2.8, 2.9%. It's most prevalent among young adults, and it's more prevalent among females than males during adolescence. While some of this information may be redundant for you, I still like to share it for those of you, especially folks who might be newly diagnosed or unsure of the difference between these diagnostic labels. I do want to emphasize that at the end of the day, treating the symptoms is the most important component of any treatment plan, because each manifestation of any disorder will be somewhat unique. But in terms of how we diagnose bipolar 1, all you need to have had is one manic episode, which is defined as elevated mood for at least a week. And it's more pronounced mood symptoms with things like, not difficulty sleeping, pressured speech, impulsivity, racing thoughts, anger, irritability, just kind of acting out of character at times. It can also present with psychotic features, which could be delusions or hallucinations that go away when the mood episode is treated. And as you can see in this graphic from the IPSRT manual, the peaks and valleys tend to be a bit higher for bipolar 1. For bipolar 2, you need to have had at least one hypomanic and one depressive episode. So depression is not a criterion for bipolar 1, but it is for 2. Hypomania is elevated mood for at least 4 days, and it's noticeable, but not always as impairing. The mood symptoms aren't usually quite as elevated. The peak is not quite as high as for bipolar 1. In terms of depressive symptoms, depression needs to last for at least 2 weeks, and usually commonly with depression, there are things like a loss of appetite, feeling kind of slowed down, either sleeping too much or too little, thoughts of hopelessness, sometimes suicidal thoughts, things to that effect. And then folks can also have mixed episodes, which present with both high and low mood. So you have symptoms of mania or hypomania and depression at once. And this is often most risky for suicidal behavior, because it seems like your body's being pulled in 2 different directions, and it can be quite overwhelming. Then there's something called cyclothymia, where there are subclinical hypomanic and depressive symptoms. As you can see, like these smaller peaks and valleys, but there's still like persistent mood disturbance. I guess you could call it bipolar 3, but it's generally just called cyclothymia. I personally never diagnosed it. I don't see it very often, or if I do, it's just harder to identify. So some of what we're talking about today is drawn from my work with interpersonal social rhythm therapy. And essentially, it was developed as a way of preventing relapse in mood symptoms for folks with bipolar disorder. I always like to say that the gold standard of care is prevention and not intervention whenever possible, because why not prevent something, then intervene if we can? That being said, intervention is important as well. In any case, the basic premise of IPSRT is that routines are essential for maintaining mental health for individuals with mood disorders, but particularly for folks with bipolar disorder. And that's because folks with bipolar disorder have sensitive circadian rhythms. Our circadian rhythm is the internal biological clock that all animals have that help kind of regulate our daily cycles. Disruption can lead to relapse in mood symptoms. Disruption can occur from a variety of factors, whether it's daylight savings or going on a trip or getting a new job or just getting out of your routine. So one of my goals for folks with bipolar disorder is to help stabilize routines. So the premise of interpersonal and social rhythm therapy is essentially, like I said, to prevent relapse in mood symptoms. And we talk a lot about how social stressors can have a major impact. And a lot of the time we think about negative stress, right? Like, say, a death in the family or losing a job. But there's also eustress, which is a Latin term, but it's positive stress. It could be a job promotion or having a baby. Interestingly, eustress is more associated with mood elevation versus kind of the negative stress, which is more likely to lead to depressive symptoms, though these factors can depend on the person and the context. So I wanted to also address important research on risk factors associated with symptoms and behaviors associated with bipolar disorder regarding interpersonal relationships. So in general, interpersonal relationships, especially challenges within them, are predictive of mood episodes. Interpersonal conflict can be predictive of suicidal behavior. In particular, heightened rejection sensitivity is a risk factor for conflict. So that was actually the concept or construct that I studied in grad school. And it's exactly what it sounds like. Sensitivity to rejection can be just it can introduce risk for challenges in interpersonal relationships because you might interpret ambiguous neutral cues negatively, which can lead to conflict or just challenges internally. Generally, individuals with greater mood episodes also struggled more in their relationships. And in youth, in particular, changes in family cohesiveness and conflict can be predictive of mood episodes, whereas in adulthood, interpersonal work stress can impact functioning. So as you can see across the lifespan, there are different stressors that come up more. Because say as an adult, you spend so much of your time at the workplace, whereas when you're a kid, you spend a lot of time at school, so peer functioning is really important. So some protective factors. Positive familial and peer relationships are really protective. More familial support and resilience are buffers against suicidal behavior. Individuals who identify as women report higher overall support based on the research. Generally, more social integration, which is like feeling a part of a community, having support is helpful for both men and women. Specifically for men, reassurance of worth, which is reassurance of self-worth or esteem, as well as guidance from a supportive person can reduce distress. Whereas specifically for women, guidance, having a supportive person reduces distress. So obviously gender and other facets of identity can impact the role of interpersonal stress in our lives. So now we're going to kind of transition into the crux of this talk, which is how to navigate interpersonal relationships. And we'll start with some relevant psychoeducation. So schemas. You may have heard this term before if you've taken psychology courses or been in therapy. If not, a schema is a concept across psychology that is incredibly important. In fact, most types of therapy address schemas, from cognitive behavioral therapy to psychodynamic therapy. There's even a type of therapy called schema-focused therapy, explicitly focused on this topic. Essentially, a schema is a broad, pervasive theme or pattern comprised of memories, emotions, cognitions, and bodily sensations regarding oneself and one's relationships with others, developed during childhood or adolescence, and elaborated throughout one's lifetime, and is usually dysfunctional to a significant degree. In terms of interpersonal schemas are patterns of thinking and feelings that are formed through experiences with important people in our lives. These patterns reflect our beliefs and expectations about how relationships work. When we experience trauma, we learn behaviors to keep us safe in that context. Unfortunately, sometimes we continue to use those same behaviors in other situations where those behaviors are not always effective or helpful. The reason I bring up trauma here is this is adapted from STARE, this definition, which is explicitly focused on trauma. But it's also relevant to folks with bipolar disorder because a lot of folks with bipolar disorder have a history of trauma. But today we will talk about specific schemas relevant to folks who have bipolar disorder. But first, we're going to talk about some relevant contextual factors. So to start, as I just said, many individuals with bipolar disorder have a history of childhood maltreatment. I actually have a specific publication on this topic. And of course, childhood maltreatment often impacts people's self-concept in all sorts of ways in terms of self-worth, safety in relationships, and feeling safe and comfortable in the world. Another major theme I see come up in my clinical work with folks who have bipolar disorder are negative schemas related to this diagnosis specifically, and shame associated with having it. In particular, many folks have talked to me about how manic and depressive episodes have impacted schemas differently, especially in their relationships with people. For example, since during mania or hypomania, elevated mood symptoms can bring up unusual behaviors out of character. Many folks I've treated have expressed fear or judgment from these episodes by people in their lives. And I've noticed this fear of judgment can become deeply entrenched and sometimes lead to subsequent depressive episodes afterwards because of the shame that can come up. And some of that can lead to a lot of internalized stigma. On another note, though, many people like the way they feel with an elevated mood sometimes, and they might feel like they're like the best version of themselves, more affable when they're experiencing mania or hypomania, which might make people less likely to take medication that can stabilize mood. These are just some examples. But another thing that I see so much that has so much of an impact on schemas, specifically interpersonal schemas around bipolar disorder, is how the media portrays the diagnosis, because there are countless myths and misconceptions around the diagnosis and how it's portrayed. And all this information can impact schemas about oneself regarding having the diagnosis. So I was just wondering, before I get into the interpersonal schemas I often see as a clinician, if anyone wanted to share or put in the chat any schemas you might experience related to bipolar disorder. I can't see the chat, so I don't know. Jake, are you able to see the chat?
Yeah, so they'll I believe we'll have some questions in the chat box come on, and then we can discuss those at the end of schemas they deal with and
Okay. Oh, now I can see the chat.
questions.
Oh, the chat is not available to me, somebody said.
Oh yeah, so the be through the question and answer box.
Okay. Okay. Well, we can get into this after. So the most common schemas I see, maladaptive, and no on maladaptive, what I mean is that they're unhelpful and can lead to more negative self-concept, mistrust of others, social isolation, feeling defective, shame, feeling of failure, some dependence or incompetence in relationships, some approval seeking, and unrealistic standards for self. I'm just wondering if this resonates with anyone. And I don't know if folks can answer that, or we can come back to this at the end. But yeah, I was just curious if this resonated with anyone. Yeah, somebody just said it resonates. Yeah. Yeah, and a lot of this, to share is based on clinical work that I do with bipolar disorder. I would say about a third of my practice are folks with bipolar disorder, and I have a relative with bipolar disorder. So this is what I've seen in my personal life as well. So we've talked about schemas, right? But we need to know what to do with them. So I've adapted this material from STARE, again, such a great framework, and it's a really useful paradigm to address schemas that come up in relationships. This is a blank sheet. Now we're going to go into one that I filled out to talk about a very common dynamic that can come up for people. So let's say you have a conflict with your partner, right? This is the interpersonal situation. And what did you think about yourself? So common feelings that come up when you have a conflict with your partner, or really anyone: anger, sadness, anxiety. You might go to some pretty negative automatic thoughts related to schemas, like my partner doesn't care about me, they're going to leave me, some catastrophic, maybe black and white thinking in terms of CBT language. So what are your expectations about the other person in terms of their feelings? Well, you might think that they're angry with you, that they're disappointed with you. You might assume the worst, that they want to break up based on the conflict. And what did you do subsequently because of these kind of scary thoughts and feelings based on your schema? Well, maybe you avoided your partner. Maybe you continued to argue, which escalated conflict. Well, how can we address this based on goals you might have in this interpersonal dynamic? Well, let's say your goal is to de escalate the conflict. Um, well, what are some alternative beliefs and feelings that can come up? In terms of feelings, maybe there's just a lot of uncertainty. Maybe things are not as bad as you think they were. Maybe things are, in a vague, ambiguous space and not as catastrophic. Maybe a thought that you have is, I'm frustrated and sad, but that's okay. Like, I'm allowed to have these feelings when I have a conflict. It doesn't mean that something inherently awful is going to happen. And maybe in terms of their feelings and thoughts, you can have maybe more kind of toned down thoughts and feelings as well. Maybe they're sitting with the same uncertainty and fear that you're dealing with. Maybe they're thinking, this is upsetting, but we can resolve this. So, what is an action that you can take here? Well, you can have a conversation when your feelings have de-escalated. I do some couples work, and I always say, when you're in fight or flight mode, not the time to, you know, de-escalate a conflict because your emotions are so intense. So give yourself some time and space to let yourself breathe and self-soothe, and then come back to engage in conflict resolution. And then from there, you might see how your partner engages with you. But this is just one example of a way in which you can view this challenging interpersonal situation differently and adjust interpersonal schemas you might have about yourself. Another relevant topic regarding the talk today is boundaries. And it's, an important focal point of this lecture because, well, it's something that we have to think about in relationships. And obviously our schemas in relationships have a big impact on our boundaries. And yeah, boundaries are a very commonly used term that mean a lot of different things in the context of therapy and beyond. So I want to be a little bit more specific. So commonly we observe three major patterns of boundaries in relationships. And it's important to note that we don't hold the same boundaries across all of our relationships. And boundaries within a relationship can evolve or change over time based on context and how our schemas change. So in terms of the major boundaries in relationships, holding others at a distance, often the pros are that you feel protected and safe and there are less or no conflict. Whereas the cons are that you're not connected, you might feel lonely, you might feel a lack of support. A lot of folks who have interpersonal schemas around feeling shame or defectiveness or like they can't trust people, I see hold others at a distance. So that's a really common thing that I experience with patients who have that interpersonal schema. In terms of fused or enmeshed boundaries, you really want to feel close and connected and in sync to your people, especially your attachment figures. And you do feel support sometimes, but it often never feels like it's enough. The cons are that you don't feel like you have enough support around your priorities, and you can lose a sense of yourself and your unique identity. And sometimes your needs and goals aren't always met because the other person's goals and needs sometimes trump your own. I see this a lot with folks who feel like they can't self-soothe or contain their emotions on their own, and they feel like they need somebody else to regulate their feelings. That's a very common schema that I have observed. In terms of healthy boundaries, you feel connected, you feel supported, you have a strong sense of your identity, and you have mutual support of your goals and your needs. But the con is that there's more uncertainty that you have to sit with because, well, there is closeness when there isn't distance, but you're not completely enmeshed. You're more likely to sometimes feel disappointed when you have healthy relationships because people don't always hold up their end of the bargain the way that we might like. It's hard work and it's not as exciting. You're not on this roller coaster. but it gives you more space. So yeah, those are some of the broad patterns that I see. And usually folks who have interpersonal schemas of confidence and competence and feeling safety in their relationship with themselves and with others can work towards having healthier boundaries. So in terms of boundaries, one of the most important skills that I work with folks on is practicing assertiveness. So what is assertiveness? Well, it's defined as standing up for your rights while respecting the rights of another person. Sometimes people confuse it or confound it with aggression, which is standing up for your rights, but you're not respecting somebody else's rights or needs. So that's a big difference. Assertiveness is really challenging, but it's also necessary to maintain healthy relationships. And from here, we're going to talk a little bit about DBT skills. But in DBT lingo, we do what is interpersonally effective, which is defined as getting our needs met while maintaining the relationship. And sometimes this involves shifting or ending relationships that are unhealthy, which can be hard to do. So from here, we're going to review some evidence-based skills. So this is my favorite. Folks love this skill. Sometimes people even write it out when they're having a conflict with someone. It's called Dear Man. These are all acronyms. But the first thing that you do in a challenging dynamic with someone is when you're talking to them, describe the situation, stick to the facts. Tell the person exactly what you're reacting to. For example, you told me you'd be home by dinner, but you didn't get here until 11. So being very factual and literal. From there, you want to express your feelings and opinions using I feel statements because you want to kind of limit the other person's defensiveness. And when you go for you statements, that automatically makes people defensive. It's important to know that you can't assume how the other person knows how you feel. So it's important to be vulnerable and express how you're feeling. For example, when you come home so late, I start worrying about you. And use phrases such as I want instead of you should, or I don't want instead of you shouldn't, again, to help diffuse defensiveness. From there, you want to assert yourself and ask for what you want, say no as needed. Don't assume that others will figure out what you want. Remember that others can't read your mind. So, for example, I would really like it if you would call me when you're going to be late. That would be one example. From there, you want to reinforce or reward the person ahead of time, so to speak, by explaining the positive impact of getting what you want or need. If necessary, you can also clarify the negative consequences of not getting your needs met. So one example would be, I'd be so relieved and a lot easier to live with if you do X, Y, and Z. Remember to also reward desired behavior after the fact. From there, you want to stay mindful, keep your focus on your goals, maintain your position, don't be distracted, and don't go off topic. A lot of times when people are in conflict, they will jump from one thing that they're upset about to the next, but it's really important to stay on topic in that moment. Sometimes we have to be a broken record, keep asking, keep saying no, or expressing your opinion over and over. Just keep replaying the same thing again and again. Ignore attacks. If another person attacks, threatens, or tries to change the subject, ignore threats, comments, or attempts to divert you. Don't respond to attacks, ignore distractions. Just keep making your point. For example, I would still like a call if the person's running late. Appearing confident is really important as well. And you can do this using a confident voice, tone, and physical manner. Make good eye contact. No stammering, whispering, staring at the floor, retreating. No saying, I'm not sure, but being direct. Lastly, negotiating. Be willing to give to get. Offer and ask for other solutions to the problem. Reduce your requests. Say no, but offer to do something else to solve the problem. Focus on what works. For example, how about if you text me when you think you might be late? And sometimes we need to turn the tables, turn the problem over to the other person, ask for other solutions. What do you think we should do? The next skill is give. So the first thing is you always, what's the saying? You get more bees with honey. I think that's how it goes. I always mess up these idioms, but in any case, Be nice and respectful. No attacks, no verbal or physical attacks. I'm sure folks are here don't do that, but in the DBT context, they mentioned that. No manipulative statements or hidden threats. Tolerate no. Stay in the discussion even if it gets painful, and exit gracefully if you have to. No judging or moralizing, because usually that isn't very effective. Or saying judgmental things like that's stupid, etc. Or I don't care what you said. Act interested. Listen and appear interested in the other person and their needs. Listen to their point of view in a genuine way. Face the person. Maintain eye contact. Lean towards them rather than away. Don't interrupt or talk over the other person. And be sensitive to their wish to have a discussion at a later time. Sometimes you need to table things. Like I said, if you're in fight or flight mode, and be patient. It's also important to validate others with words and actions. Show that you understand the other person's perspective, feelings, and thoughts about a situation. See the world from their lens. And then act or say on what you see. So I realize this is hard for you and blank. I see that you are busy and blank. So validating where they're coming from. Lastly, using an easy manner is always helpful. Use a little humor, smile, ease the person along, be lighthearted, sweet talk. Use a soft sell or over a hard sell, and be political. Leave your attitude at the door. Basically, you want to do what works, what can help maintain the relationship to get your needs met and to also help satisfy the other person in some way. The last skill we'll go over from DBT is fast. Be fair to yourself and the other person. Remember to validate your own feelings and wishes as well as the other person's. A lot of people struggle with apologies where people aren't apologizing from a genuine place. I'm a big believer in apologizing from a genuine place, but over apologizing usually isn't coming from there. Don't apologize for being alive or making a request or having an opinion or disagreeing. No looking ashamed with eyes and head down or body slumped. No invalidating the valid. Stick to your values. Don't sell out your values or integrity for reasons that aren't important. And be clear on what you believe is the moral or value way of thinking and acting. Stick to your guns. Lastly, it's important to be truthful. Don't lie. Don't act helpless when you're not. And don't exaggerate or make up excuses. So being genuine is really crucial to relationships. So in summary, in terms of our discussion today, to leave some time to talk, interpersonal stress is predictive of mood episodes. Our schemas or concepts about ourselves have a big impact on how we function in relationships. Many people across diagnoses struggle with maladaptive schemas, especially when it comes to mental health related to internalized stigma. So it's crucial to consider alternative evidence, thoughts, or feelings that can in turn shift our behaviors and internal narratives about ourselves and others. It's really important to practice assertiveness and to set healthy boundaries because it's crucial to well-being. And it is a form of behavior that can shift our relationship patterns. It's something that we do have control over. Positive intra and interpsychic experiences are protective and should be prioritized. And what I mean by intra is like our internal relationship, how we feel about ourselves, whereas inter is like our relationships with others. So I'm really curious today to hear, when we get into discussion, what your experience is with practicing assertiveness, what makes it hard, what makes it helpful, and do any of your schemas inform whether or not you think you can be skillful? Just some questions that are food for thought. Thank you so much. We're going to do some discussion in a moment. Feel free to reach out to my work email if you have any questions. And now we're going to go into question and answer. I'm going to stop sharing my screen so we can interact.
Excellent. Well, Dr. Freitag, thank you so much for that presentation. And like that was just said, we're going to go into our question and answer session of today's webinar. So please drop your questions into the question box, and we're going to get to as many as we can while also touching on previous discussion points that were left throughout the chat. So first, I think it would be good to go over one of our audience members was having trouble navigating how her husband perceived her, and they were only mentioning episodes many years later. So is there any sort of way to navigate others' perception on you based on previous episodes?
Just to clarify the question, what is meant by episodes years later?
Let's see. If we don't get an immediate response from our attendee, let's go with the situation that episodes happened in the past and they're still being brought up by their partner.
So someone is holding it over their head, kind
Hmm.
of, and not letting go of previous history.
Right.
Well, I think in, the DBT framework, we want to do what is effective and skillful while still validating our own needs. And I would articulate how bringing up those previous episodes make you feel in this moment, but also while doing that, try to understand the other person's perspective. Maybe it's coming from fear or uncertainty about how things will look like in the future, even if you've been in a period of wellness for a long time. But I think understanding the other person's feelings while acknowledging your own, which are completely valid and would be very frustrating to have someone routinely bring that up, might lead to effective conflict resolution. But I am guessing it probably comes from a place of fear more than anything, and maybe understanding that fear and addressing it could lead to effective resolution.
Thank you for that. And so we'll go into our next discussion point, which is one of our audience members would like to know how to get through a negative schema from a psychotic episode. And they believe that judgment can be much harsher, especially from oneself.
Yeah, no, that's a really important question. I mean, a lot of folks who have dealt with psychosis, whether in the context of a mood episode or psychotic spectrum disorder, um, I've heard them self-label like extremely terrible, inaccurate things like crazy or other really negative labels that I think are based in myth and misconception from news and media. And I think a lot of it is just by addressing the insight and work that you have done and are doing to take care of yourself, and that calling yourself names and creating more internalized stigma is not helpful in the healing process. And a lot of it comes from unhelpful, negative societal attitudes that are fortunately really starting to shift around these things. And a lot of folks who haven't struggled haven't put in the work that many of you have on yourselves. And there's so much beauty and value in that. And I think there's so much growth that has come from pain and struggle. And I think recognizing your growth and resilience is the best way of confronting internalized stigma for those of you who have had those experiences. And also, those experiences come from, brain chemistry. It's out of your control. They're highly genetic. It's not something that you could control for. So I think letting go of some of that control and recognizing that it's just something in your brain that happened that you're treating and addressing and dealing with is all we can do. But judging ourselves for having those experiences isn't helpful.
Mm, That's such an important reminder. So our next question is if there are any practices to navigate conflict at work.
Yeah, well, that's an important question because, we spend so much of our lives at work. I mean, I think a lot of the DBT skills are relevant here. I think one of the challenges at work is like entrenched power dynamics, especially when you're dealing with someone who might be senior to you. So it really depends on like the level of power that person has, if you're on the same level or if they're junior or senior. And I think you can bring in the same skills that we covered today while acknowledging the reality of who you're relating to. How we talk to a supervisor or someone senior to us is going to be different than a colleague, unfortunately, which can be really frustrating and stressful. But I think practicing a certain degree of assertiveness can go a long way, as scary as it is. In
Mhm.
order to get something, we have to speak up for ourselves sometimes, and that can earn us a lot of respect. And I think just being mindful of our language, being really specific about the thing that we want met. For example, let's say you want a raise. That's one of the biggest things that come up. Like being able to advocate for yourself and present a rationale or argument for the work that you put in to have earned this raise, and um, to be confident, kind of like what DBT talks about, no kind of apologizing or assuming that you're not worthy of it, but assume that this is something that you deserve, and practicing confidence in that context can really go a long way in terms of faking it till you make it, which is not easy, but um, can be an effective strategy at work.
Mhm. Well, thank you for that answer. And going forward, our next audience member wants to know any tips for interacting with a family member that has a strong personality and they think that they know them better than themselves.
So they think they know you better than themselves.
Yeah, so the family
Okay.
member believes that they know our audience member better than they know themselves.
Okay. That's a good question. We all have those family members. It's hard, with our family versus chosen family sometimes. I mean, a lot of it is setting boundaries. Even sometimes, I think broken record in terms of, you know, topics that you just don't want to talk about, just saying, I don't want to go there, and just being explicit and direct. But if that person doesn't respond to those boundaries that you set, internally setting your own boundaries, knowing when you feel like picking up the phone if they're not going to respect the boundaries that you've tried to set. But I think being clear and respectful in your communication with someone who's defensive, I would always keep that in mind and not go for the jugular, knowing that they might be less receptive to certain types of personalized feedback, unfortunately. But knowing what your boundaries are in that relationship is what's most important. Actually, the session before this talk, I had this discussion with someone around a relative. So sometimes when we're communicating with someone who has their own limitations, we just have to recognize who they are, who we're dealing with, and accept reality for what it is. So much of DBT is accepting reality. If someone has certain limitations, right, that's just who they are. But what are our boundaries in terms of how we're going to navigate the relationship? When are we going to pick up the phone? What are the topics we're going to decide to say, you know what, like this is not worth going there because it's just going to lead to conflict.
Mhm. So our next question reads, I'm wondering if you have any tips on how to trust yourself that you can handle interpersonal relationships. I have bipolar 1 and I'm starting a new romantic relationship for the first time in a long time. And I'm so nervous that it's going to lead to a mood episode, but I also truly want to have a partner. And I also want to thank you so much for this presentation and appreciate the information.
Thank you. Well, I think it's awesome and brave that you're putting yourself out there and doing something that is a little scary. I think that's so much about what builds confidence, putting ourselves out there and challenging ourselves to do the things that can scare us sometimes. And things are always going to be scarier at first. But for example, the premise of exposure therapy is doing things that are hard over time get easier because we expose ourselves to the things that we're afraid of. And I think a lot of it is just practice, 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 like putting ourselves in challenging situations and seeing what it feels like, and being vulnerable with ourselves and others to build safety and a genuine connection. But, it sounds like based on the way that you describe things, you have a lot of insight and awareness that this is something that is a little scary. And that's a valuable starting point, knowing that something is scary and working towards creating that safety within yourself and within the relationship.
Mhm. And then, so our next question is if there are any good prevention tactics before entering a relationship to ensure that the relationship is healthy. For example, not a fused or disconnected relationship. So if there's any work that they can do before the relationship begins to put themselves in a good position.
I think a lot of it is knowing your negotiables and non-negotiables in terms of like what you're looking for in terms of the characteristics of a person that allows you to feel safe. There are certain personality characteristics that don't lend themselves to that. I think making sure that the other person is in a healthy space, that you're in a healthy space, and it's coming from a place of wanting someone to add to your life in a positive way. For example, in enmeshed relationships, there's like the expectation that the other person's going to help you like soothe your own emotions. And that can create kind of codependency. Whereas if you're in a space where you can take care of yourself, you can soothe yourself, you might select for a very different type of partner. But I think really being able to identify your values and the characteristics that align with those values will allow you to select a healthier partner. But really looking out for like certain warning signs around, how a person treats important people in their lives. Like being like almost like a curious scientist in the beginning. I know like that doesn't sound very romantic, but I think sometimes we can get like sucked into exciting situations where we don't see a person clearly because of the excitement. And at the end of the day, you need to like the person you love. And sometimes it's hard to like someone who doesn't treat us or the people in their lives with respect. And I think respect is the foundation of every healthy relationship, like whether romantic, platonic, otherwise.
Well, thank you for that answer. And we're going to move forward with our last question of the day, which reads, can you speak to trusting yourself while having loss of introspection as one does with bipolar disorder?
So is that specifically, I'm wondering, during an episode or, you
Um,
know,
there's no clarification as of now, but let's do that.
well, I think a lot of the important work in managing bipolar disorder is building the introspection during a period of wellness to kind of know warning signs like, I don't feel myself, I haven't been sleeping, my energy levels are changing either up or down, but building awareness of your trigger points, the things that are major stressors for you, your warning signs, can help you kind of prevent relapse and mood symptoms. That's the goal of IPSRT, because the truth is, when you are like fully in the throes of specifically elevated mood, it can be harder to have that introspection. The same can be the case when you're in like a darker, deeper depression. So, really focusing the work on the well period. But I also think building a support system of people who can be your, support person, like I mentioned before, because that was protective for everyone. Having people in your life who can check in with you and support you, maybe when you're losing like a sense of introspection, whether it's an important loved one or your treatment team. I think that's so crucial and foundational to taking care if you're having a mood episode. We all need a support system when we're going through a hard time, whether you have bipolar or not. So I think that's really foundational, in my opinion.
Well, thank you for that answer, Dr. Freitag. And with that, I'd like to thank everyone in attendance today. If you would like to rewatch the recording, it will be available at ibpf.org and on our YouTube channel, International Bipolar Foundation. And we're just so honored to have Dr. Freitag speak with us today. And it truly was a great time, very informational. And Dr. Freitag, do you have any closing comments?
Thank you so much. I really enjoyed speaking with all of you. Feel free to reach out if you have any questions. And yeah, it's such an honor to be able to talk with IBPF. And Jake, you're always wonderful. So thank you, and really appreciate you all attending today.
Excellent. Well, thank you. And with all that being said, I hope everyone has a great day.